Good afternoon. I'm Commander Anna Kahn, Associate Director for Communication with the Division of Environmental Health Science and Practice in the National Center for Environmental Health at the Centers for Disease Control and Prevention. I'd like to welcome you to today's Nexus webinar on commemorating 30 years of CDC funding childhood lead poisoning prevention programs. There will be a presentation, a panel discussion, and a Q&A session. All participants joining us today are in listen-only mode. Closed captions are available for this webinar. Next slide, please. A recording of this webinar will be available in the next few days at Nexus webpage at cdc.gov/NCEH/EHSP/EHNexus. Next slide, please. You may submit questions at any time during today's presentation. To ask a question using Zoom, click the Q&A button at the bottom of your screen. Then type your question in the Q&A box. Our CDC subject matter experts are looking forward to addressing your CDC-specific questions during our Q&A session. If you're a member of the media, please contact CDC Media Relations at media@cdc.gov or at 404-639-3286. Next slide, please. I would now like to welcome our presenter for today's Nexus webinar. We're pleased to have with us Dr. Paul Allwood. Dr. Allwood is the branch chief of the Childhood Lead Poisoning Prevention Branch at CDC's National Center for Environmental Health. And now I'd like to turn it over to Dr. Allwood. Dr. Allwood, please proceed.
Thank you, Anna. Good afternoon, everybody. It's my pleasure to welcome all of you to this live virtual event. Since 1991, CDC has supported state and local health departments through cooperative agreements, which allows those recipients to conduct childhood lead poisoning prevention activities all across this country. These state and local programs are the foundation of what we do. And today we want to commemorate 30 years of funding these programs. And this is an incredible milestone for all of us, for our partners, for the CDC, and for public health in general. This signifies years of coordinated efforts to protect children from lead poisoning through many noteworthy accomplishments that were achieved along the way. But this milestone is also an opportunity for us to think about the future and move toward our shared goal of eliminating childhood lead poisoning, childhood lead exposure as a public health problem. We have some exciting items planned for the next hour. First, we will begin by discussing some of the key accomplishments in lead poisoning prevention and current initiatives here at the CDC. Then we will hear from some of our funded childhood lead poisoning prevention programs about the work they're doing every day in their communities. We will conclude with a question and answer segment. First, it is my pleasure to welcome and introduce Dr. Pat Breysse, who is the director of CDC's National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry, to present some opening remarks. Dr. Breysse.
Thank you, Dr. Allwood. A pleasure to be here with you today, and happy morning or afternoon, wherever you might be. So as Paul mentioned, after recognizing that lead exposure is harmful to children with negative effects that can last for a lifetime, CDC began funding state and local childhood lead poisoning prevention programs in 1991. That was a long time ago. CDC is leading efforts to prevent childhood lead exposure, which continues to impact several million children every year. As of 2021, we fund 62 state and local public health programs who conduct lead poisoning prevention activities in their communities. The program has some ups and downs, but it's happy to see the extent of the coverage that we have today. We're supporting nationwide efforts to eliminate lead exposure where children live, learn, and play. And we provide valuable resources to inform and educate families, healthcare providers, and public health professionals. We've made many contributions to the field of public health, but there's more to be done. As we move forward, we must continue to maximize our impact on children and communities in the US and beyond. We need to bridge disparities that exist based on race, ethnicity, and income, and prevent lead exposure before it occurs. As we celebrate our 30th anniversary in 2021, we invite you to join us at CDC commemorating our continued commitment to preventing childhood lead exposures in the United States. Thank you very much for your attendance, and I'll turn it back to Dr. Allwood. Paul?
Thank you very much, Pat. Now I would like to discuss some significant scientific and public health events in childhood lead poisoning prevention that has occurred over the last 30 years and more. CDC has a long-standing role in childhood lead poisoning prevention. Over the last 30 years, CDC and its partners have made progress towards eliminating childhood lead exposure in the United States. Some of these will be highlighted in this presentation. However, despite our progress, we are aware that much work still needs to be done. So this is not meant to be a victory lap. Next slide, please. To begin, the fight against childhood lead exposure really took off in the 1970s, when we saw some of the first nationwide initiatives to ban lead from various sources. During this time, the EPA initiated a health-based regulation to remove lead from gasoline for on-road vehicles and began setting limits on the amount of lead in drinking water. In 1973, the Consumer Product Safety Commission banned hazardous amounts of lead in toys and other products intended for use by children and required warning labels on other lead-containing products. Next slide, please. Oh, and if I could say on the previous slide, if you could please go back to the previous slide, there's an important point to make there. Most importantly, I think perhaps one of the most stellar and significant accounts was that lead was officially banned from consumer paint in 1978. Next slide. In the 1980s, CDC started sharing screening recommendations and treatment guidelines with state and local public health agencies. The Lead Contamination Control Act of 1988 authorized CDC to support local and state agencies to develop comprehensive childhood lead prevention programs. And then in 1989, the Advisory Committee on Childhood Lead Poisoning Prevention, or ACLIP, was established. Next slide, please. The 1990s was a very pivotal decade for childhood lead poisoning prevention at CDC. In 1991, CDC began funding state and local childhood lead poisoning prevention programs. Along with establishing CDC's program, other federal agencies instituted some critical efforts. HHS released the Strategic Plan for the Elimination of Childhood Lead Poisoning and set forth a comprehensive plan to eliminate childhood lead poisoning. And EPA published the Lead and Copper Rule. Next slide, please. Additionally, CMS adopted CDC's universal screening requirements for children receiving Medicaid benefits. And a ban on food cans with lead solder became effective, and leaded gasoline was phased out from most motor vehicles. Next slide. At the start of the 21st century, the President's Task Force on Environmental Health Risks and safety risks to children, recommended eliminating childhood lead poisoning. Also, the EPA enacted the renovation, repair, and painting rule, which continues to protect children attending childcare centers and living in older homes undergoing renovation. And then in 2009, CDC released its guidelines for the identification and management of lead exposure in pregnant and lactating women. These guidelines are still in use today. Next slide. In the years following 2010, we saw a turning point for childhood lead poisoning prevention. By this time, lead poisoning prevention had been declared a public health success, since children with blood lead levels over 10 micrograms per deciliter was less than 1% of US children. This was largely due to national policies that control lead sources like paint, water, gasoline, and consumer products. With this, CDC stopped the use of the term blood lead level of concern and replaced it with a population-based blood lead reference value to identify children with higher levels of lead in their blood compared to most children. But the events in Flint, Michigan led to a renewed attention on childhood lead poisoning and the need for efforts to identify and remove lead from the children's environment became a matter of much urgency. There is no safe lead level for children. Many children are still exposed, suffering from harmful effects, even at extremely low blood lead levels. With this renewed focus and shifted vision, CDC established the Flint Lead Exposure Registry to help identify and connect victims of the Flint water crisis to necessary services. CDC also established the Lead Exposure and Prevention Advisory Committee, or LEPAC, and reinstituted funding for state and local lead poisoning prevention programs. This is just a snapshot of all the milestones that have occurred over the last 50 years. A full timeline is available on our website, and I encourage you to check it out. Next slide, please. So where are we today? Well, to begin, we recently awarded funds to the most expansive set of cooperative agreement partners in the program's history. 62 state and local public health agencies now have cooperative agreements with the CDC. We also have many other exciting things happening for lead poisoning prevention at CDC. For example, in collaboration with the American Journal of Public Health, we are preparing to publish a supplemental issue on the topic of lead hazards, prevention, mitigation, and emerging sources of exposure. We are currently accepting submissions, and more information about the supplement is available on our website. Our branch is also in the process of developing a new lead poisoning prevention training package for public health professionals. The anticipated launch date for the first portion of the training is expected to be later this year. We are also excited that the Lead Exposure Risk Index, or LERI as it's referred to, will soon go live. The LERI will provide an interactive dashboard for individuals, the public, and professionals that map lead exposure across the country. Next slide, please. Together, we've accomplished a lot over the last 30 years. However, there's still more work that needs to be done. Not all children are receiving their required blood lead tests and getting connected with the services they need. This issue is especially timely right now as there is a shortage of point-of-care blood lead test kits due to an FDA recall. This, of course, is exacerbating an already challenging issue. However, it is critical that we focus all our efforts on ensuring that children receive required blood lead tests. Millions of children are still exposed to lead in their environments, and the children at risk for lead exposure are likely to live in neighborhoods characterized by older homes, lower family incomes, lower housing values, higher population densities, higher proportions of rental properties, and higher proportions of minority, immigrant, and refugee residents. Higher blood lead levels are also more prevalent among children from racial and ethnic minority groups, children from low-income households, and children who live in buildings and housing built before 1978. Next slide, please. As certain populations bear a disproportionate burden of lead exposure and its associated risks, the future direction of our program is deeply rooted in health equity. Looking to the future, our priorities include pursuing health equity and community-based interventions for lead poisoning prevention, improving our data to be more timely, complete, and accurate. We also want to increase blood lead testing, particularly among children that are most at risk, including those that are underserved. And we want to increase awareness of childhood lead poisoning as a major public health problem in the US and abroad. As childhood lead exposure in the United States has evolved, so has our program and the approaches that we've taken to reduce and eliminate the problem. We are very pleased to have so many partners working at the federal, state, and local levels to accomplish these priorities, and we thank you all very sincerely. And now I will turn it back to our moderator, Anna Khan.
Thank you, Dr. Allwood and Dr. Breysse. Dr. Allwood, I would like to ask you a few questions before we go into the panel discussion. My first question is, what has been the greatest accomplishment in fighting lead poisoning over the past 30 years?
Thank you, Anna. That's a very important question. And what I would say is that in the 70s, blood lead levels were very high in the United States. The average blood lead level for US children, ages 1 through 5, was 15 micrograms per deciliter. Because of the persistent efforts by CDC and our partners, average blood lead levels in this population decreased by more than 14 micrograms per deciliter by 2016 to now less than 1 microgram per deciliter.
Thank you, Dr. Allwood. My next question is in reference to the lead poisoning prevention. What health disparities and environmental justice issues exist?
Again, thanks for that question. Lead exposure is commonly found in low-income housing that was built before lead was banned in consumer paint in 1978. Of course, with time, weathering, and other physical deterioration, lead paint will turn into dust, flakes, or chips that kids can ingest. And once ingested, lead can cause hearing and speech problems, slowed growth and development, damage to brain and the nervous system, and other health issues. Some children have a higher chance of being exposed to lead in their environments than others. African-American children and children who live in households at or below federal poverty level are more likely to live in housing built before 1978 and are at greatest risk for lead exposure. Also, some countries have less stringent restrictions on lead in materials such as paint, cosmetics, and natural remedies. So children who are immigrants, children who are adopted from a foreign country, and refugee children are more likely to have higher blood lead levels.
Thank you, Dr. Allwood. You mentioned that blood lead levels have declined tremendously over the past few decades. So my last question is, why is there still so much effort being placed into lead poisoning prevention?
Yeah, that's also another great question, Anna. Millions of children are still exposed to lead in their environments. And of course, as I mentioned, there are significant disparities in exposure based upon race and income. Children at greatest risk for lead exposure are primarily concentrated in neighborhoods with older homes, lower family incomes, lower housing values, and higher population densities. We must continue to put an effort into tackling lead poisoning by promoting primary prevention and testing children at risk. Testing and identifying children with higher blood lead levels can help limit additional exposure by identifying and eliminating the sources of lead in that child's environment, which will reduce their blood lead levels over time. I understand that right now, many programs are facing extra strain as a result of the recalls related to the point of care devices. But it is critical that we focus our efforts on maintaining screening, particularly for children from low-income backgrounds and communities of color. This issue is extremely important to CDC, and we empathize with you about the extra strain that the recalls are placing on your programs. It is critical that we work together to ensure that children continue to be tested and connected to the services they need.
Thank you, Dr. Allwood, for providing us with this important and timely information. For our next portion of our presentation, it is my pleasure to turn it over to Ms. Rio Schondemeyer, who will lead the panel discussion. Ms. Schondemeyer, please proceed.
Thank you, Anna. My name is Rio Schondemeyer, and I am a health scientist at CDC's Childhood Lead Poisoning Prevention Program. I'm excited to host our panel discussion with 4 CDC-funded recipients. Next slide, please. Participating panelists include Michelle Meyer from the South Carolina Lead Poisoning Prevention Program, Ed Norman from North Carolina Childhood Lead Poisoning Prevention Program, and Dr. Trina Evans-Williams from the Louisiana Healthy Homes and Childhood Lead Poisoning Prevention Program. Unfortunately, Beverly Druin, who would have represented the New Hampshire Department of Health and Human Services for this panel discussion, could not attend today. So she prepared her responses ahead of time, and Madeline Jones, a member of our team, will be reading her responses during the panel discussion in her stead. Next slide, please. Our first question for the panelists is, what are your Childhood Lead Poisoning Prevention Program's greatest accomplishments or successes? I will turn it over to Trina from Louisiana first.
Good morning, everyone. It's an honor to be here with everyone to share today. Our 3 major accomplishments that we would like to highlight is our lead testing at WIC clinics in high-risk parishes of the state of Louisiana. Our first pilot projects, we tested over 2,000 children for lead in the highest risk regions of the state, and 80% of those children were first-time testers. Additionally, with funds used from CDC and the Association of Maternal and Child Health Programs, we implemented an innovative testing strategy at one of the WIC clinics. As a result, we tested over 1,500 children at this one clinic using the Plan, Do, Study, Act, which is the PDSA model. So we were very excited about that. We also want to emphasize our major collaborations with multiple partners to provide community and professional trainings and host annual community events for National Lead Poisoning Prevention Week over the many years, as well as National Healthy Homes Month. Throughout those annual activities, and especially during Lead Week, we were able to educate over 1,500 providers within that week. And those providers included pediatric residents that was a part of the Tulane School of Medicine as well, program hospital, as well as Grand Round Series within the hospital systems here in the state of Louisiana. We've been a recipient for CDC for many years and have had the pleasure of sharing our experiences by also mentoring other CLIP programs of recipients and helping them to achieve their goals as it relates to WIC lead testing, as it relates to awareness activities such as Lead Week and education outreach activities as well. So thank you all. We presently have been asked by CDC to assist one of our states with social media and ways to use social media to promote our key messages as well. So that's our newest mentoring activity. Thank you all.
Thank you, Trina. Those are great accomplishments to be proud of. Next, I will ask Ed from North Carolina the same question. What are your CLIP's greatest accomplishments or successes?
So in North Carolina, our greatest accomplishments and successes include the decrease in blood lead levels over the past 30 years and development of a blood lead and environmental surveillance data system to enhance all those efforts. More recently, legislation passed in 2017 to decrease blood lead levels, the action levels that we use to match CDC guidelines, warranted interventions by state and local public health agencies, as well as the inclusion of pregnant women in those efforts. And finally, maintaining and growing the reach of North Carolina's Lead and Healthy Homes Outreach Task Force by including nearly 300 individual members and dozens of agencies. The task force has consistently met quarterly and is engaged and forged partnerships for more than the 30 years that I have been a CLIP staff member. That's all.
Thank you, Ed. And now let's hear Beverly's response, which Madeline Jones from our CDC branch will provide about New Hampshire's accomplishments and successes.
Yeah, thank you, Rio. New Hampshire's greatest accomplishment is successfully using our surveillance data to identify priority populations and geographic areas that need focused initiatives. We have used our CDC funding to successfully keep a full-time epidemiologist and health educator on staff, and they have collaborated to use our surveillance data to tell the story of lead poisoning across the state. New Hampshire annually publishes a statewide lead exposure data brief and 13 targeted regional data briefs. Also, our health educator has been successful in educating medical providers and parents on the importance of lead testing. Our article, Successfully Changing a State's Climate to Increase Blood Lead Levels, published in the Journal of Public Health Management and Practice in 2019, was part of this effort and also allowed us to share best practices with a larger audience. It was a follow-up to a 5-part integrated strategy implemented to increase testing rates of 1- and 2-year-old children statewide.
Thank you, Madeline. For our next question, we are interested in hearing our panelists' response to what are you looking forward to working on in the future? First, I will ask Michelle from South Carolina to respond.
Well, thank you, Rio. In South Carolina, we are excited about the possibility, or not possibility, about developing a statewide steering committee to help us. We will be building on Ed's expertise from the past 30 years. We also think that there's a lot more that we can do to address perinatal lead exposure. There's our recommendations for what to do if a pregnant woman has an elevated blood lead level, but there aren't recommendations about when to routinely test her. So we want to work on that. And we also want to continue our work to have an admission criteria for early childhood intervention be the child's blood lead level and not the often delayed notification that the child has some kind of cognitive issue. We want early intervention to be available based on the blood lead level. So that's 3 things that we're hoping to work on over the next 5-year grant cycle.
That's great, Michelle. Next, let's hear from Ed on what North Carolina is looking forward to working on in the future.
So we're putting an effort into increasing testing rates among Medicaid recipients, particularly, including pregnant women and children younger than 6. And we aim to reach 100% of these populations. We're also growing a surveillance and primary prevention programming in high-risk rural communities in North Carolina, which, although not high density, are very high prevalence for lead poisoning. And we are also pursuing legislative changes for increased funding, particularly for remediation of high-risk housing.
That's great, Ed. We're very impressed with your goal to reach 100%. Next, let's hear Beverly's response, once again provided by Madeline Jones, on what New Hampshire is looking forward to working on in the future.
Yeah, New Hampshire is looking forward to working with the CDC on the Healthy Homes and Lead Poisoning Surveillance System, or HELPS as it's referred to further develop the clinical and environmental modules to meet the needs of programs using the application.
Thank you, Madeline. CDC appreciates New Hampshire's help in developing those modules for our surveillance system. Our next question is, what types of obstacles has your program overcome? Michelle, would you like to respond first?
Happy to do so. Our program lost we lost our funding in 2006 when the CDC's criteria for funding changed. We no longer met the criteria. And due to that loss of funding, all our CLIP staff were reassigned to other jobs. Over the next few years, we had just a skeletal surveillance system. We did lead assessments for foster homes, and we borrowed the lead assessment staff for children who had 15s or 20s. Some of you may remember that higher lead intervention level. However, during that time, our local nurses continued to hear about lead exposure cases, and they worked with the limited staff to connect as many families of lead exposed children to services as possible. We were able to often identify lead hazards in primary and secondary residences. Almost all our efforts to identify lead exposed children also were done by hand or hand typed or written during that time. We only started getting state and federal funding to expand our services following, of course, as everyone knows, the Flint water crisis. From July 2017 through the end of the 2021 fiscal year, we were awarded $2.2 million in state dollars and $1.87 million in federal dollars to support the work of over 60 staff members on our statewide lead team, most of whom are providing in kind. So we've gone from 0 to 60, literally. Since our program was expanded in 2017, we have a better ability to detect lead exposed children. Reports have increased from 30,000 to over 60,000 per year. We have increased our ability to investigate cases from a maximum of 8 to over 50 per year, with full investigations, enforcement, court if we need it, nursing case management, and this is the best, resolution of the elevated blood lead level and rectification of the hazards. So we're very proud of our ability to have resurrected a program and be able to do it again.
Thank you, Michelle. You certainly have a lot to be proud of. Trina, can you now tell us about the obstacles that the Louisiana program has overcome?
Yes, our program has overcome many obstacles. However, I will mention 2 of them. One was we undertook a major robust initiative entitled the St. Joseph Lead and Water Initiative that occurred in 2018. Every day we had sit-rep reports with our Secretary of Health, who then reported to our governor. Our leadership at the Louisiana Department of Health worked with our program to provide health education and lead testing information to affected families, to provide environmental assessments of the homes of all the affected families, and outreach to pediatricians about the importance of lead testing in the affected areas. And so on March 13, 2018, our governor announced the completion of a new water plant in the town of St. Joseph, and he lifted the public health emergency. From that robust activity and campaign, $8 million was generated in order to create a new system in that area. And it was from state capital outlay funds, and $600,000 additionally from the Delta Regional Authority was also supplied. And so the Louisiana Department of Health conducted one of the most comprehensive responses to lead exposure ever. And we spent more than $220,000 in testing more than 430 sites, performing environmental assessments to all homes with lead levels in excess of 50 parts per billion, and reviewing blood lead levels of children under the age of 6. In addition to that, we also, when the budgets of CDC Child Lead Poisoning Prevention Program recipients were severely reduced in 2012, our leadership at the Louisiana Department of Health, as well as our genetic diseases program, came up with creative and innovative solutions to cover all program costs by using state general funds, and all staff staff positions were fully funded. No child was left behind. Care coordination services were ongoing. Surveillance was ongoing. And that is just an example of how we were able to successfully accomplish our obstacles. Thank you.
Thank you, Trina. Now let's turn it over to Ed to hear what obstacles the North Carolina CLIP has overcome.
So recent increases in take-home exposures from battery manufacturing employees in the Winston-Salem area of the state provided a great opportunity actually for partnership between the CLIP program and the adult blood lead epidemiology and surveillance program, as well as the North Carolina State Laboratory of Public Health, in which we were able to address many of those concerns and continue to monitor those facilities. Concern over exposure to drinking water after the Flint, Michigan episode was really the catalyst for a partnership that was created with RTI International, a major research facility in the Research Triangle Park, and NC Child, which is a very effective statewide advocacy organization. And we were able to capture funding and adopt rule amendments to require water testing in all childcare, licensed childcare facilities for lead in particular. So this partnership has received supplemental funding since that time from the EPA through the Water Infrastructure Improvements for the Nation Act. And we anticipate some additional legislative funding later this year, potentially. Overall, the importance of non-paint sources of lead has gained attention in recent years, and we have partnered with state and local health, housing, and nonprofit agencies to address those sources of lead exposure. Some of our joint efforts to address contaminated cultural products include creating a web-based library of cultural sources of lead exposure, and educational handouts in multiple languages about different spices, and incorporating information about cultural sources of lead exposure into trainings for public health professionals.
Thank you, Ed. For our next question, we're going to look back over the past 30 years. Madeline, can you describe how North Hampshire's lead poisoning prevention, or how lead poisoning prevention in New Hampshire has changed over the last 30 years?
Yeah, thanks, Rio. I am proud that CDC has been instrumental in lowering the blood lead level that initiates follow-up action. When I started the program, New Hampshire's action level was 20 micrograms per deciliter, which was then lowered to 10 micrograms per deciliter, then to 7.5 micrograms per deciliter, and is 5 micrograms per deciliter right now, matching the CDC recommendations.
Thank you, Madeline. I'm sorry. Thank you, Madeline. And now, Trina, how do you think lead poisoning prevention has changed over the past 30 years?
Lead is one of the major environmental hazards for children in America. However, exposure to lead can be prevented. There is no safe level of lead in children's blood lead, and even at low levels, children are affected. This is why over the years, the blood lead level that triggers public health action has dropped significantly.
Thank you, Trina. And now let's ask Michelle for her response.
Sure. I've noticed a decreased tolerance for children living with lead hazards and having lead in their blood. This seems to be a more recent development and is perhaps associated with the Flint water crisis. But I've also noticed a recent increase in providers having concerns about what was once considered an incredibly low level of lead. For example, a provider will call us about a child with a blood lead level of 2.0 micrograms per deciliter because they're aware that the geometric mean for these values is already below 1. And so they're concerned about that. Nobody ever expressed those kinds of concerns before. And I'm glad that we're understanding more about the risks associated with even low levels of lead and lower levels of exposure. There's also increased awareness of the need for lead testing and increased confidence that we can actually find and address the lead hazards. At the start of my public health nursing career in '85, I worked at a EPSDT well child clinic, and I don't recall us ever doing lead testing of children. I just don't think it was on our radar. But in '91, as I moved into a different type of position, I clearly recall questions being asked as we looked at lower values. Could the instrumentation on our analyzers actually get a result that, this is an unheard of level down to 10? Our work to find sources of lead still mainly identifies hazards associated with paint, but we also find lead hazards in water, pottery, spices, makeup, toys, incense, other ritual items, employment at lead foundries and indoor shooting ranges, even a case where old lead gas had dripped onto a children's play area. We're identifying blood lead levels that need follow-up care quickly, and we use our shared lead surveillance database to engage with our referral partners, such as nurses and lead risk assessors.
Thank you, Michelle. Certainly a lot has changed over the last 30 years. And for me, it's exciting to hear personal stories from people who have been in the profession for so long. Our last question for the panel is, how has CDC supported your CLIP efforts? And everyone on the panel will have the opportunity to answer this question, starting with Trina.
CDC has truly been an instrumental part of our program's success. As a result of CDC's support, longstanding support, our program is expanding its services to the most high-risk parishes of the state of Louisiana, which in itself is a very impoverished state in the nation. We've increased our ability to target interventions such as education and outreach to high-risk geographic areas and populations. We've increased knowledge and awareness among the public health professionals, childhood lead poisoning prevention workforce members, and other key and essential partners. We've also increased the identification of children with blood lead levels above the blood lead reference value who received appropriate linkages to recommended services and follow-up services as well. So we appreciate this long-time partnership and look forward to working together to accomplish great things. Thank you.
Thank you, Trina. And now let's hear Ed's response.
So funding from the CDC has really directly allowed us to enhance our surveillance efforts. CDC, although we don't use the data systems that are technically supported by the CDC and never have, the CDC has always provided guidance over the years in building clinical and environmental surveillance databases. Additionally, the CDC has facilitated opportunities for the CLIP programs to engage with each other to address emerging challenges involving lead, such as the Lead and Spices Working Group.
Thank you, Ed. And now, Madeline, can you tell us how the CDC has supported New Hampshire's CLIP efforts?
Yeah. Over the last year, the CDC Helps team has worked intimately with the New Hampshire programmatic staff, in addition to New Hampshire's Department of Information Technology, in onboarding the new Healthy Homes and Lead Poisoning Surveillance System. Also, the CDC Office of General Counsel played a key role in helping New Hampshire's health educator understand funding requirements for the publication of our recent children's book, Healthy, Happy, Lead-Free Me.
Thank you, Madeline. And now, Michelle, how would you respond to this question?
Well, our CDC project officer has been a wonderful cheerleader for our program, as well as a facilitator for discussions and brainstorming, not just with our state, but among other states in our region. Most importantly to us, though, our project officer has been both prompt and thorough in getting us definitive answers to our questions, even when they are incredibly complex. We have never felt like we had to guess about anything. We knew that our project officer would put us in contact with the best sources for answers. We have great expectations for our new project officer and great gratitude for our previous one.
Thank you, Michelle. What a great discussion. We are so proud to hear about the impact that CDC has had on our funded recipients over the years, and we hope to continue to build upon these efforts in the future. Thanks again to each of our panelists for joining us today and commemorating 30 years of funding and highlighting their programs on this panel. And now I think I will pass it over to Anna Kahn for the next session.
Thank you so much, Michelle DeMeyer. That was an amazing session. I'm so happy to hear from our states on what they're doing as well. We will now go over into our Q&A session. So please remember to ask a question using Zoom, click the Q&A button at the bottom of your screen, then type your question. Our first question states, what does CDC recommend to parents and the public to do to reduce lead in children's environments?
All right, thank you for that question. For parents or caregivers, first step is to find out the year the home was built, because in homes or buildings built before 1978, it's a safe assumption that the paint contains lead, unless it had been tested and proved otherwise. There's also likely to be lead in the soil around older buildings, either from the exterior paint or from vehicle emissions. If the home was built before 1978, we would recommend that you do the following. Talk to a healthcare provider about having your child tested for lead. Have the home checked for lead hazards by a licensed lead inspector or a certified risk assessor. A lead risk assessor can check for lead-based paint hazards, as well as if there are any hazards in the soil. For people who are renting, you should ask your landlord to have the home checked for lead.
Thank you, Dr. Allwood. The next question is...
Oh, I'm sorry, Anna. Maybe can I just add a few other things to that first response?
Yes, of course.
I think there are also some additional preventive actions that I think people should be thinking of, and these include, having, a qualified professional fix up surfaces in the home that may have peeling or chipped or cracking paint. Making sure that there is attention paid to removing shoes or wiping off soil from shoes before entering the home, especially those that are living in older homes where lead paint could still be an issue. Washing children's hands, their bottles, their pacifiers and toys often. Also making sure that children eat nutritious meals that's high in iron and calcium. And for adults who work with lead, or they have hobbies that include use of lead, making sure that work clothes are kept away from children and kept outside of the home. Those are some additional things that you can do.
Thank you, Dr. Allwood. The next question is, when will CDC update the blood lead reference value?
Thanks for that question. CDC's Federal Advisory Committee, which is known as the Lead Exposure and Prevention Advisory Committee, or LEPAC, took a unanimous vote that recommended updating the blood lead reference value. And an official announcement on the blood lead reference value update will be coming out very, very soon.
Thank you, Dr. Allwood. The next question is, why is CDC planning to update the blood lead reference value?
Well, as I mentioned, the Federal Advisory Committee, known as LEPAC, took a vote that was unanimously in favor of lowering the reference value to 3.5 micrograms per deciliter. As many of you know, it's now 5 micrograms per deciliter. The reference value is based on data derived from the 97.5th percentile of the blood lead level distribution among children under 6 years, using 2 cycles of NHANES data. The current recommendation is based upon NHANES data from 2015 through 2018 cycles. Since the vote that took place in May of this year, the CDC has been taking steps to implement this update. And as I said earlier, an announcement on this will be coming very soon.
The next question asks, you say the focus of your program is heavily rooted in health equity. What is CDC planning to do to address social and economic disparities in pediatric lead exposure?
Right, again, thanks for this question. It's a very important question. CDC's lead poisoning prevention program is rooted in the principles of health equity and environmental justice. And both of those, health equity and environmental justice, are major priorities of the CDC. Health equity is achieved when all people have the opportunity to achieve the highest level of health that they're capable of achieving. We have expanded funding to support 62 state and local programs to conduct lead poisoning prevention activities. This is the largest set of cooperative agreements in the history of our program. Our funding strategy aims to promote public health action to improve health equity through strategies and activities that will eliminate disparities in blood lead levels based on social, demographic, and geographic factors. And we ultimately aim to eliminate childhood lead poisoning as a public health problem. CDC is in the process of updating our population-based blood lead reference value. And this will also help CDC and its partners focus resources on children at higher risk for lead exposure, which are more often children from underserved and racial minority communities.
Thank you, Paul. The next question is CDC still funding the Flint Registry?
Yes, CDC continues to fund the Flint Lead Exposure Registry through a non-research grant that goes to a consortium of investigators, including those from Michigan State University, who are working in partnership with the city of Flint, the Greater Flint Health Coalition, and others. In 2021, CDC awarded MSU $3.6 million to continue the Flint Registry for an additional year.
Okay. The next question has two parts. Can you elaborate on the supplemental issue you're preparing for the American Journal of Public Health? What kind of papers are you looking for?
We are working in close collaboration with the American Journal of Public Health to publish a supplement on that will include topics related to lead hazards, lead poisoning prevention and mitigation programs, and emerging sources of lead exposure. The supplement will address and contribute to comprehensive understanding of currently known and also emerging sources of lead. The deadline to submit is January 30th of 2022. And you can get additional information about the supplement on the American Journal of Public Health's website.
Thank you. The next question asks, you mentioned that not all children are receiving the required blood lead tests. How can state and local governments increase blood lead testing in their communities?
Thanks again. This is a really important issue. You know, testing is kind of an essential. It is an essential part of the programs that we do here at the CDC and at our other partners. In order to increase testing in communities, we recommend providing outreach and education about lead poisoning prevention to families as well as to their healthcare providers. We also recommend partnering with community organizations and also using targeted screening methods. We also recommend that some effort be placed into identifying and assessing barriers to testing that exists in communities. We have seen some indications that the pandemic and the recent recall of the lead care devices are further suppressing testing. We are looking at our data to understand this better and to also understand ways that we can apply to deal with this problem. Information about this recent recall and the MMWR about decreases in blood lead testing, which we published earlier this year, can be found on our webpage.
Thank you, Paul. The next question asks, you mentioned children can be exposed to lead from multiple sources. How else can children be exposed to lead other than lead in paint?
There are a variety of other sources of lead exposure. Major sources, apart from paint, include contaminated soil around older homes and roadways, drinking water from lead contaminated or lead containing plumbing. Products such as toys and jewelry can also be contaminated with lead. Food stored or prepared in lead glazed lead glazed containers or dishes. Jobs and hobbies that involve working with lead, from which lead can be brought home, is also a source of potential exposure. And air and soil contaminated with lead from aviation fuel around airports can also be a source. There are other sources that we provide on our website, and I encourage everyone to take a look, see what additional sources there are.
Thank you, Dr. Allwood. We have time for just one more question. And the next question is, what other activities are happening during National Lead Poisoning Prevention Week?
Okay, tomorrow, October the 28th, CDC is hosting a webinar called Childhood Lead Exposure in the United States, CDC's Role in Prevention, Education, and Surveillance. The webinar will cover sources of lead in children's environment, populations at higher risk, current trends among children in the US, prevention strategies, and current CDC initiatives. It will be broadcast in English and Spanish. Spanish version will take place from 10 to 11 a.m. Eastern Time, and the English version will take place from 2 to 3 p.m. Eastern Time. Several other activities are occurring, and a full schedule of the activities is available on our website.
Okay. Thank you, Dr. Allwood. This concludes our Q&A session. I would now like to turn it back over to Dr. Allwood for closing remarks.
Thank you, Anna. I just want to express my deep gratitude to everyone who participated in this live virtual event. The panelists, whom you've all heard from and who have spoken, with great excitement about the partnership that they've had with the CDC and some of the important work that they're doing within their communities. And to all of you who have listened in, I want to say thanks for what you do each day to help to get us to the goal of eliminating childhood lead poisoning as a public health problem. And while we're doing that, with a laser-like focus on the pernicious and almost intractable disparities that we have seen, where certain populations are at much greater risk for lead exposure than others. I want to thank all of you for being here again, and I look forward to continuing to work together as a team, CDC and its partners, to continuing to advance the mission of lead poisoning prevention across the country. Thank you very much.
Thank you. Thank you so much, Dr. Allwood. And thank you as well to our panelists for joining us for today's Nexus webinar. If you have additional questions, you may email them to ehnexus@cdc.gov. Again, thank you for joining us for today's Nexus webinar, and have a great day.